HELLP syndrome, recognition, management, and delivery in pregnancy. HELLP syndrome, occurring in 0.2 to 0.8% of all pregnancies and 10 to 20% of severe preeclampsia cases, is a life-threatening variant of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelet count. The pathophysiology involves systemic endothelial dysfunction, placental ischemia, and activation of the coagulation cascade, leading to microangiopathic hemolytic anemia and hepatocellular injury. Diagnosis requires laboratory confirmation of hemolysis, lactate dehydrogenase greater than or equal to 600 U/L, AST/ALT greater than or equal to 40 U/L, and platelets less than or equal to 100,000/μL, with the Tennessee and Mississippi criteria providing standardized definitions. Immediate delivery remains the definitive treatment, with corticosteroids, antihypertensives, and magnesium sulfate for seizure prophylaxis forming the cornerstone of pre-delivery management. Key points. Note: HELLP syndrome occurs in 0.2 to 0.8% of all pregnancies and affects 10 to 20% of women with severe preeclampsia. The Tennessee criteria define HELLP as platelet count less than or equal to 100,000/μL, AST greater than or equal to 40 U/L, and LDH greater than or equal to 600 U/L, with or without peripheral smear evidence of hemolysis. Magnesium sulfate is administered as a 4 to 6 g intravenous, 4, loading dose over 15 to 20 minutes, followed by 1 to 2 g/hour continuous infusion for seizure prophylaxis. Labetalol is first-line antihypertensive, 20 mg for initially, then 40 mg after 10 minutes, then 80 mg every 10 minutes up to a total of 300 mg, or 100 to 200 mg orally twice daily. Delivery is indicated for all patients with HELLP syndrome at greater than or equal to 28 weeks gestation. Expectant management may be considered at 24-27 plus 6 weeks with maternal stabilization. Dexamethasone 10 mg for every 12 hours for 4 doses is recommended in cases of severe thrombocytopenia, 50,000/μL, or imminent delivery before 34 weeks. The maternal mortality rate for HELLP syndrome is 1 to 2%, with a perinatal mortality rate of 7 to 60% depending on gestational age and severity. AST and ALT are typically elevated to greater than or equal to 40 U/L, but levels greater than 200 U/L are associated with increased risk of hepatic rupture, or 4.2, 95% CI 2.1 to 8.3. The Mississippi Triple Classification System stratifies HELLP into Class 1, platelets less than or equal to 50,000/μL, Class 2, 50,000/100,000/μL, and Class 3, 100,000/150,000/μL, with Class 1 having the highest complication rate. LDH greater than or equal to 600 U/L is required for diagnosis and correlates with hemolysis, with levels greater than 1,500 U/L indicating severe disease. Peripheral blood smear should show schistocytes in greater than or equal to 2% of red blood cells to confirm microangiopathic hemolytic anemia. Systolic blood pressure greater than or equal to 160 mm of mercury or diastolic greater than or equal to 110 mm of mercury requires immediate antihypertensive therapy within 30 to 60 minutes per ACOG 2023 guidelines. Overview and epidemiology. HELLP syndrome, hemolysis, elevated liver enzymes, low platelets, is a severe, life-threatening complication of pregnancy, classified under the spectrum of hypertensive disorders of pregnancy, particularly preeclampsia. The ICD-10-CM code for HELLP syndrome is 014.13, preeclampsia, severe with HELLP syndrome. It occurs in 0.2 to 0.8% of all pregnancies and affects 10 to 20% of women diagnosed with severe preeclampsia. The incidence varies by region. In the United States, it is estimated at 0.5 to 0.7 per 1,000 deliveries, while in Europe, rates range from 0.3 to 0.9 per 1,000. In low-resource settings, underdiagnosis may lead to underreporting, but population-based studies from sub-Saharan Africa suggest a prevalence as high as 1.2% among preeclamptic pregnancies. The condition predominantly affects women of reproductive age, with a median age of 27 years, range 16 to 45. It is more common in multiparous women, 60 to 70% of cases, compared to primiparous, 30 to 40%, although primiparity remains an independent risk factor, RR 2.1, 95% CI 1.6 to 2.8. Racial disparities exist. Non-Hispanic Black women have a 2.3-fold higher risk, RR 2.3, 95% CI 1.8 to 3.0, compared to non-Hispanic white women, even after adjusting for socioeconomic status and access to care. Hispanic and Asian populations show intermediate risk, with RR 1.4 and 1.2, respectively. Pathophysiology. HELLP syndrome arises from systemic endothelial dysfunction, a hallmark of preeclampsia, driven by abnormal placentation and subsequent release of antiangiogenic factors into the maternal circulation. The pathogenesis begins with defective trophoblast invasion of spiral arteries during early placentation, weeks 8 to 18, leading to persistent high-resistance uteroplacental circulation and placental ischemia. This ischemia triggers oxidative stress and the release of placental debris, including syncytiotrophoblast microparticles, cell-free fetal DNA, and antiangiogenic proteins such as soluble FMS like tyrosine kinase 1, SFLT1, and soluble endoglin, SANG. SFLT1 binds to and neutralizes vascular endothelial growth factor, VEGF, and placental growth factor, PLGF, disrupting endothelial integrity. The resulting endothelial activation leads to vasoconstriction, increased vascular permeability, and procoagulant state. This cascade manifests as hypertension, proteinuria, and end organ damage. In HELLP syndrome, the liver is particularly vulnerable due to its dual blood supply and high metabolic activity. Clinical presentation. The classic triad of HELLP syndrome, right upper quadrant, RUQ, pain, nausea/vomiting, and hypertension, is present in only 10 to 20% of cases. More commonly, symptoms are nonspecific. The most frequent symptom is malaise or fatigue, reported in 70% of patients. Nausea and vomiting occur in 60 to 70%, often misattributed to gastroenteritis. RUQ or epigastric pain is present in 50 to 60% and is typically dull, constant, and localized to the right upper quadrant due to hepatic distension or subcapsular hematoma. Shoulder pain, Kehr's sign, may indicate diaphragmatic irritation from hepatic hemorrhage and is a red flag for impending rupture. Hypertension, systolic greater than or equal to 140 mm of mercury or diastolic greater than or equal to 90 mm of mercury, is present in 85% of cases, with severe hypertension, greater than or equal to 160/110 mmHg, in 60%. Proteinuria, greater than or equal to 300 mg per 24 hours or 1+ on dipstick, occurs in 75%, but 15 to 20% of patients lack significant proteinuria, especially in early onset or atypical cases. Key points: systolic BP greater than or equal to 160 mm of mercury or diastolic greater than or equal to 110 mm of mercury, requires treatment within 30 to 60 minutes. Platelets 50,000/μl, increased bleeding risk. AST/ALT greater than 200 U/L, risk of hepatic rupture. LDH greater than 1,500 U/L, severe hemolysis. Diagnosis. Diagnosis of HELLP syndrome requires a high index of suspicion and laboratory confirmation. The two most widely used criteria are the Tennessee criteria and the Mississippi criteria. The Tennessee criteria require, key points, platelet count less than or equal to 100,000/μl. AST greater than or equal to 40 U/L, LDH greater than or equal to 600 U/L, evidence of hemolysis on peripheral smear, schistocytes. Management and treatment. Immediate stabilization is critical. All patients should be admitted to a labor and delivery unit or intensive care unit, ICU, if hemodynamically unstable. Monitoring includes continuous maternal vital signs, fetal heart rate tracing, urine output, goal greater than or equal to 30 milliliters per hour, and neurological assessment. Airway, breathing, and circulation must be assessed. Oxygen is administered if SpO2 less than 95%. Intravenous access with 2 large bore, 16 to 18 G, lines is established. Fluid balance is carefully monitored, excessive fluid administration, greater than 100 milliliters per hour. References. 1. Zarni S. et al. Acute fatty liver in pregnancy, literature review. Curious. 2025, 17, 10E94576. PMID, 411-63637, https://pubmed.ncbi.nlm.nih.gov/411-63637. DOI, 10.7759/curious.94576. 2. Sharma R. et al. Ruptured subcapsular liver hematoma, an atypical and life-threatening presentation of HELLP syndrome. European Journal of Obstetrics, Gynecology, and Reproductive Biology. 2025, 313:114633. PMID, 407738814. https://pubmed.ncbi.nlm.nih.gov/407738814. DOI 10.1016/J.EJOGR.2025.114633. 3. Fralkes A. et al. Liver conditions specific to pregnancy, optimizing management and outcomes. The Turkish Journal of Gastroenterology, the official journal of Turkish Society of Gastroenterology. 2026, PMID, 4202778, https://pubmed.ncbi.nlm.nih.gov/4202778. DOI 10.5152/TJG.2026.26024. 4. Nyo S. et al. HELLP syndrome with hepatic and thoracic complications, insights from a case of spontaneous liver rupture. The American Journal of Case Reports. 2025, 26 E949380. PMID, 408156118, https://pubmed.ncbi.nlm.nih.gov/408156118. DOI 10.12659/AJCR.9493880. 5. Garcia Gonzalez LA et al. Ruptured subcapsular liver hematoma as a rare complication of HELLP syndrome. A therapeutic challenge. Revista Española de Enfermedades Digestivas. 2023, 115, 8465-466. PMID, 36426863, https://pubmed.ncbi.nlm.nih.gov/364266863. DOI 10.17235/read.2022.9276/2022. 6. Ismail N. et al. Preeclampsia complicated by HELLP syndrome in a prima gravida, a case report. Curious. 2025, 17, 3E80770. PMID, 402557882, https://pubmed.ncbi.nlm.nih.gov/402557882. DOI 10.7759/curious.80770. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.